I will talk today mainly about coronary guide wires. I will show my personal understanding of those wires in general and my personal approach. So coronary guide wires are 0.014-inch wires, and they have three components. They have the core, which can be 19-0 or most often stainless steel, and I will describe each one of those a little later. You have the tip, which is the last 3 to 20 centimeter of the wire, and which is the soft part of the wire. The tip evidently is very important, and there are various variety of tips. One, the tip usually has a spring coil, which is what you see here. It always has a spring coil. Within that tip, you can have a continuation of the core. You can have a continuation all the way to the end of the wire, which is what we call core to tip, or the core can finish early and the wire has a shaping ribbon at the end. Okay, so it could be core to tip, or the core can finish early before reaching the very end of the tip. The core to tip gives you more torqueability and directionality, whereas that non-core to tip, pure spring coil at the end, gives you more flexibility, as in the BMW wire, for example. Most wires are core to tip. Another description of the tip is that sometimes not only the core inside it, but the whole tip is tapered, meaning the whole tip is not 0.014-inch, it's 0.010-inch or 0.009-inch. This is particularly the case in some CTO wire. Another description of the tip is the weight of the tip, meaning how much force does it take to bend that tip, and it's described in grams. We call it low weight soft tip when usually the tip is less than 1 gram in weight, and heavier tip when it's over that. It can go up to 20 grams, and the heavier the tip, the more it is a risky tip, but the more it is useful in complex CTOs. Okay. The third component of the wire, and the most important component in distinguishing between guide wires, is actually what we call the coating. The coating, which can often extends all over the core and the tip, but sometimes it only covers the core and part of the tip, not the very distal portion of the tip. Okay, and I'll describe that in a little bit. So the coating is the single most important feature distinguishing the wires, and there are two big types of coating. You have the polymer coated wires and the non-polymer wires. And that's how I distinguish wires as a first big differentiation. Is the wire polymer coated or non-polymer coated? Polymer coating, if you know the peripheral glide wire, which is that extremely slippery wire, this is what polymer is. It's an extreme form of hydrophilic wire. Non-polymer wires, and here is where a confusion is seen in interventional cardiology sometimes. Non-polymer wires are frequently hydrophilic, but a lot of interventional cardiologists use the term hydrophilic to imply polymer wire. That's very different. Most non-polymer wire are hydrophilic. But when we use the term polymer, we're implying we're very hydrophilic, okay? It's a different level of hydrophilicity. Actually, most workhorse wire are hydrophilic, but no workhorse wire is polymer coated. Polymer is important because it makes the wire very slippery, meaning very deliverable, very trackable, easy to track across functional CTO or subtotal occlusions and across tortuosity. So it's a very useful type of wires, but it has its risks. Hydrophilic, on the other hand, is better than hydrophobic, but it's way inferior to polymer in those features, but it's also way safer in that regard. So workhorse wires are non-polymer wires, but they are often hydrophilic. Now, sometimes workhorse wires are hydrophilic, but they can also be what we call hybrid, meaning the hydrophilic coating is over the core and maybe part of the tip, but it doesn't reach the very tip. Again, most workhorse wires are hydrophilic. I'll give you examples: the BMW wire, for example, the Pro Water wire, Samurai. Most of those have some degree of either full hydrophilic or hybrid coating. Okay, so that's the first big distinction between wires. And this slide shows you the type of coating for wires. You can have either hydrophobic or no coating, which is the least slippery and trackable and lubricious wire, or you can have hybrid coating, hydrophilic over the core, hydrophobic coating over the tip, or full hydrophilic coating, or polymer coating, the super hydrophilic coating. And this is the grading increase in lubricity and trackability. So this slide is one of the three most important slides of that talk. I tried to put together here, the way I classify and I see wires. And I divided them in non-polymer and polymer coating, which is how you should first approach those wires. And each category, I subdivided it into multiple subdivisions. So one, and I tried to give you names of the most commonly used wires. I use mainly the Asahi, Abbott, and Boston Scientific. So the non-polymer wires, again, often hydrophilic or hybrid hydrophilic and phobic. You have the big category of workhorse wires, which imply usually workhorse have low tip weight, usually less than 1 to 1.2 gram tip. And here you have the examples of BMW and Minamo. BMW is 0.6 gram tip, and those are nitinol core. Then you have a bunch of wires like Pro Water and Samurai, Samurai RC, and Cheon Blue. Those are stainless steel core wire. That core can be stainless steel most often, or it can be nitinol, and I explain the difference. Okay, so workhorse can be stainless steel or nitinol, and you have that unique wire run through by Terumo, where the core is actually both nitinol and stainless steel into the tip, both nitinol and stainless steel. Again, within those, you'll find other distinctions, such as BMW, the core doesn't reach the very end of the tip, whereas in Pro Water and in those wires, Samurai, the core does reach the tip, which gives you more torqueability, potentially a little less flexibility of the tip. Okay, so that's the first distinction, workhorse wire. Then in terms of polymer wire, you have also the low tip weight, which are at the same level as the workhorse, except they are more risky. Even though they have a tip weight as low as the workhorse wires, they are polymer, so inherently more slippery, more risk of dissection and perforation. Because the more lubricious you are, the less tactile feedback you get, the more that wire will slip in places you want, like in occlusion and across tortuosity and across calcium, but it can slip in places you don't want, like plaque, subintima, and distal, causing a perforation. So the low tip weight, my favorite is Whisper, which is a 1 gram. Those are other ones, Pilot 50, Xion Black, Fielder FC. Those are not workhorse wires, but those are the first wires to use in complex cases where you want something more trackable and more deliverable than a workhorse wire. So they are the second type of wires to use, okay? Now, the third category of wires is within the non-polymer. I'll go back to the non-polymer. You have the heavy tip CTO type of wire. And this is one of the most famous one. If you go to meetings like TCT, this is one of the most famous CTO wires, is Gaia 2nd. It is, again, non-polymer, heavy tip, and it is tapered. A lot of the CTO wires are tapered, meaning that tip area, the full tip with the spring coil tapered to less than 0.014, such as in this case, 0.011, 0.012. With the Judo, you go to 0.008. With the confianza 12, you go to 0.009. So what tapering does, it makes you have a greater force over a smaller area, which provides more penetration power in microchannel. It also can cause more perforation. That's why those are higher risk wires, okay? So those are the heavier tip weight CTO wire. Gradually you increase from the Gaia 2nd, one of the most popular one, to the Confianza Pro and Hornet 14, which are the more potent, the heaviest one, the most potent and heaviest one. Now, in terms of polymer wire, two additional categories that are used in CTO, you have the low tip weight, like Whisper and Sheon Black and Fielder FC, but it's low tip with tapering, which increases the penetration into microchannel, but also increases the risk. Those are used in simple CTO. The most famous is Fielder XT, which tapers to 0.009, and you have Fighter by Boston Scientific, which is fairly similar to Fielder XT, also taper. Then you have the heavy tip polymer CTO wire, and those are the two very famous ones. Again, you'll hear those names very commonly in meetings. You need to know those names. Pilot 200, which is 3.9 gram, and Mongo 3 grams. So those are on average lower tip weight than those, the non-polymer, but being polymer, that provides them more penetration and almost as much of a risk of perforation as the heavy tip non-polymer. So I hope everybody understand that big classification of wires, okay? Non-polymer, I split them into two, and the polymer, I split them into three, but mainly two, the low tip weight and the heavy tip weight for CTO. So I mentioned, particularly for the workhorse wires, there are the two types, the nitinol and the stainless steel. What's the difference here? It's not a super important difference. It's nothing as important as that classification, non-polymer, polymer, and tip weight and tapering. That's the most important thing. But there is a slight difference, and nitinol, it is a more elastic and flexible type of material than stainless steel. It torques better in tortuous anatomy and is more durable. The tip retains its shape when you go through tortuosity, or if you inadvertently push it more than you need to. The tip does not get damaged. It's kink resistant, more than the stainless steel. Conversely, stainless steel is more robust body for support, and it provides a little bit more of a push and torque, but it is less flexible than nitinol. That's why, as a workhorse, my preferred wire is BMW. But the stainless steel ones are totally fine. Again, slightly more torque, slightly more support. You lose a little bit of flexibility. Okay. Here are some of the wire properties. Some of the biggest properties of wire you're looking for: trackability, flexibility, deliverability. This is dramatically increased with polymer wires. It is somewhat good with hydrophilic wire and with nitinol wire. It is least good with hydrophobic wire, especially hydrophobic stainless steel wires. Why does polymer wire provide great trackability? Let's say you have a calcified tortuous vessel. The more you have hydrophilic, extra hydrophilic polymer coating, the less likely it is for the body of that wire to be stuck against the calcium and against the tortuosity, and the less likely it is to find resistance for you to further advance it distally. And that's why for tortuous vessel, for heavily calcified vessels, the polymer wire can come very handy. In addition to crossing tight stenosis, tightly calcified stenosis, and microchannel, you want that slippery capacity, and this is where polymer wires come handy, including the first line polymer wires. Outside CTO, your first access should be to those first line polymer wire in complex disease. Okay. Now, in terms of tactile feedback, stainless steel is the best. Stainless steel non-polymer wire is the best. You lose a lot of the tactile feedback with polymer wires. Another thing in terms of support, of course, the less polymer, the less hydrophilic, the more support you get, because it is less likely for that wire body to slip. Again, it's more likely to be stuck against the vessel and less likely to bend as you're trying to advance your stent and your balloon. The less hydrophilic, the less slippery, the more support you get from the wire. And the more you get it also from a stainless steel core. I will now provide various subtypes of lesions and what are my favorite wires for every subtype of lesion. So one subtype, very common, is the tortuous arteries. I mentioned one of the best wires for those are the soft polymer wire like Whisper or Sheon Black. Depending, of course, how tortuous, how many bends you have to go through, and how calcified that tortuosity is. The more calcified the tortuosity, the more bends you have to go through. Say if you have to go over through more than 2 bends with calcified tortuosity, the more likely I will be to use a soft polymer wire. If you have 2 bends or less and you're not heavily calcified across those bends, then I would use a workhorse wire, especially soft tip, flexible tip, not core to tip BMW wire, nitinol. Okay, that will be useful, Minamo as well. Or you can use a soft tip stainless steel wire, such as the Sheon Blue, which has a very soft tip, 0.5 grams. Or you can use Suo. Suo is the softest tip wire. It's used for collateral crossing, but it can be used in tortuous artery. It has a 0.3 gram tip. You will hear that in meetings as well, that name. I want to distinguish, Sheon is one of the popular wires. I want you to distinguish the 3 types of Sheon. They used to confuse me at one point. You have the Sheon Blue is a workhorse wire, stainless steel, hydrophilic, non-polymer. So the Sheon Blue is a workhorse wire. Sheon Black is a polymer wire. Sheon is a non-polymer wire that is not usually used at workhorse. It is low tip weight, but it's often used for collateral crossing. So Sheon Blue, workhorse, Sheon Black, low tip weight, polymer wire. Regular Sheon is collateral crossing. Now, I mentioned tortuous artery. How about critical calcified stenosis? You can try a standard workhorse wire, especially BMW, but my favorite wire for those, and sometimes I would directly start with a soft polymer wire, such as Whisper or Sheon Black. Now, if you have tortuous and critical calcified stenosis, then I would start with a soft polymer wire, okay? Now, how about if you have thrombotic lesion, such as an STEMI or a non-STEMI with a large thrombus burden? Here, still the preferred wire is a workhorse hydrophilic wire, such as BMW, ProWater, Samurai RC. But depending on the case, especially if the first one failed, and sometimes as a first line, depending on your judgment, you can use a Whisper wire, or like meaning a soft polymer wire. And that really depends on how much you think that thrombus is subacute and organized. The more subacute and organized it is, the more you want a slippery wire to go and slip through it, okay? The more you will have resistance crossing it, the more you would, because the more it will have a scar in it, and the more you would want a slippery wire trying to slip through the microchannels. I will move to talking about CTO, and that is the second most important slide in that talk. I will describe the CTO antegrade wire escalation. There are 4 wires, essential wires that are used in CTO wire escalation. You will hear those wires, again, very frequently talked about in CTO meetings. So the basic one is the Fielder XT, which, like I described earlier, this is a Fielder XT. It's here. It's a polymer, low tip weight, but tapered. So that's your first line of CTO wire, antegrade crossing. 0.8 gram, but tapered. The second line, you know, if let's say you start with Fielder XT, this phase, your second line, it's one of those 2, but typically it's Gaia second, which is non-polymer, somewhat heavy tip, not very heavy tip, intermediately heavy. It's Gaia second is 3.5 gram. Alternatively, or sequentially, you use polymer intermediate weight tip, such as Pilot 200 and Mongo, as I mentioned again in that slide, Pilot 200 and Mongo. So you progress from this to this, and lastly to those, Confianza and Hornet 14. And I'll show here. So the last step after you failed in those first three is to do Confianza Pro 12 or Gaia third, both of which are tapered and heavy tip. This one is 12 gram, or you can use also Hornet 14, which is 14 gram tapered tip. This one is high penetration tip, high force, non-polymer, and the tip is also tapered. So it's not just high weight tip, it's also tapered, 0.009 typically. Okay, so that's my progression across those four. You're more likely to start with a Fielder XT if you have a tapered tip like this one, not a blunt tip, especially if you also have microchannels. But even if you don't have microchannels, if you have a tapered tip where it's easier to cross in general antegradely, it's good to start with a safer one and can be more successful in those cases compared to the blunt tip, blunt cap CTO, where Fielder XT is less successful than those other ones, and you may directly start with one of those depending on the operator's preference. Okay, then upgrade to that. So that's grossly the 4 stepwise approach to CTO antegrade wire escalation. I want to tell you briefly what is, Gaia. Why is this kind of wire so popular? Gaia, like many of those CTO wires, is made by Asahi. And this is what makes Gaia special. The tip, beside the tip load, it has, I mentioned wire tips have a spring coil. Well, Gaia has double spring coil. You see this, and you have another material, Act 1, another spring coil over the core that reaches the tip. And the core reaches the tip as well. It's core to tip. So both those things, as well as the hydrophilic coating, that doesn't reach the very distal tip, but covers most of the body and the tip. So that hydrophilic coating and that double spring coil and the core to tip makes the Gaia a very torqueable wire, even in the midst of a CTO, which allows you to continue to have control as you're trying to cross a CTO. So that's kind of the advantage of it. It's flexible, yet it's very torqueable and controllable in CTO. This Gaia, which is here, okay? I'll just show you some picture of what I described. I showed the Gaia. I'll show you the Pilot 200 and Mongo again. So the Pilot 200 has a big polymer sleeve on it, and it's a close to 4 gram tip. You have the Mongo, it's also very popular. It's a little less tip, 3 gram, also full polymer sleeve covering the tip, and it's core to tip. Those are the fourth step, which is the Confianza Pro 12 or the Hornet 14. Those are the tapered tip wires. Both of them actually have, the Confianza and the Hornet and the Gaia actually have hydrophilic coating that typically does not reach the very tip. It reaches all the way except that very last 1 millimeter. But that also provided some, with some deliverability, especially the body as you're crossing the CTO. And this is what we call hybrid coating, just to remind you. As you read the charts of wires, I want you to be able to understand what they describe here. Tip stiffness, which is the tip weight, coating, which can be, again, polymer, hydrophilic, hydrophobic, or what you call hybrid, meaning hydrophilic over a certain length and hydrophobic over some parts of the tip of the wire. The second description I will give regarding CTO wires is, here I describe how to progress antegradely. Now to give you the wires used in other types of CTO crossing. So when you fail in your antegrade CTO crossing, then you decide, you tried those 4 wires or a combination of them, and now it's time, you failed, now it's time to upgrade to another strategy, such as antegrade dissection reentry or retrograde wiring. And those are the wires that are typically used for those strategies. So the antegrade dissection reentry, you try to create a wire knuckle behind the occlusion in the subintima. And there are 3 wires that are used for this. All 3 are polymer wires. You can use the Fielder XT and the Mongo, which are here, Fielder XT and Mongo. Those 2 wires will give you small knuckle and small subintima and potentially easier reentry, less subintimal hematoma, would compress the true lumen distally. And Pilot 200 will give you a bigger knuckle. So those are the wires for subintimal dissection reentry. The second category of wires here will be the CTO retrograde septal wiring. And those are the 4 wires that are commonly used. 2 of them are polymer soft wire, the Fielder FC and the Xion Black. Polymer, soft tip, non-tapered. You can use also soft, non-polymer hydrophilic wire, the Xion and the Suo, which is, again, has the softest tip, the lowest tip weight, 0.3 grams. It is a matter of operator preference. All those 4 are acceptable options. And you can change around. If you fail septal crossing in one, you can switch to another one, especially between polymer and non-polymer. Then you have CTO retrograde epicardial wiring. And here the preferred wire are usually those 2, which are also used in septal wiring, Xion and Suo wire. But you can also use the Fielder FC wire, which was mostly popular when those 2 weren't available. Okay, so I hope everybody understands this slide. This is the third most important slide. Again, if you attend the meeting, they will be talking about those wires all the time. They may not explain to you what each wire is, and they may not show you that stepwise approach to each case. So try to print this and keep it with you when you go to meeting if you are a fellow, and that will be helpful, I hope. I mentioned Xion before. Again, Xion blue is a workhorse wire, but the Xion that I describe here is a very soft, non-polymer hydrophilic wire that is used in CTO retrograde crossing, whether septal or epicardial crossing. And again, Xion Black is different. So there are 3 types of Xion, so we don't get confused. Xion Black is a polymer soft, non-tapered wire, which is used, which can be used as in standard cases when you want to use low tip polymer wire. In standard complex cases, like you use a whisper, you can use Xion Black, but you can also use it in retrograde septal wiring as well. The last category of coronary wire I want to describe is the simplest category. The other one are the most important one. The other classification and the 3 big slides are the most important slides I want you to get of this talk. But there is another subcategory of wire aside from everything I described, which is the heavily supportive wire. There are wires that have not just not a heavy tip. Their tip is soft, but they have a very heavy body. Those are wires that are used for support. If you want to deliver, they may allow you to deliver a stent and balloons that you haven't been able to deliver over a soft, especially over a polymer wire. So they tend to have a heavy body, not heavy tip. So Ironman, Mailman, Grand Slam, and BHW, which is balanced heavyweight instead of BMW. So those wires have heavy body. They are stainless steel, which provides more support than 19-all. They have a very light tip, so they have a soft tip, but heavy body. It's something like in the peripheral wire, something like Amplat Super Stiff. It has a soft tip, but a heavy body to allow you to deliver devices. They tend to be, they can be hydrophilic, but most often they are hydrophobic. Again, they don't want to be slippery at all. They want you to be stuck against that wall and not slipping against it as you're trying to advance devices. They want you to be attached to that wall. They can be used as body wire in tortuous complex PCI. I don't think those are good wires to cross a lesion, because they are so heavy and so non-slippery and non-deliverable, it will be hard to cross tortuosity and cross a lesion with the body of those wires. You may cross with the tip and the body is stuck. You're not going to be able to cross either the lesion or the tortuosity. But I think they are good as an adjunct in cases when you're using a body wire on top of your original wire, okay? It's also, for me, when I do peripheral vascular intervention and I have to use 0.014 inch after crossing a lesion, those are my wires of choice, not for crossing, but after crossing, to give me support for delivering atherectomy or balloons or stents, such as a drug-coated balloon in the periphery. You need a lot of support to deliver those. So anyway, those are overall the coronary guidewire description. Here, I want to show you the three big slides I showed earlier. This one, that one, the CTO antegrade wire escalation, and that CTO antegrade dissection and retrograde wiring. I want you, try to print those three slides and keep them with you. They can be helpful to you in meetings, okay? Now I want to describe, after describing all the wire, I want to describe some other wire technique now, how to use those wires. It's a matter of style and every operator is different. Every operator has his own style, but I will describe to you my personal style of how to wire lesions, okay? My personal preference. So one, the wire band. I think there is a lot of art in how to shape your wire tip. This is how I do it. I typically put two bands, one about 4 to 6 millimeter proximal and one about 1 to 2 millimeter distally in this shape, okay? Now, where do I put the proximal band and how much I sharpen that proximal band depends on what branch I'm trying to reach. So let's say I'm going from the LAD and I'm trying to wire the diagonal. The length of that proximal band, where I put it, how far back I put it, depend on the diameter of that LAD. The larger the LAD, as I'm trying to get a diagonal, the further back I put that proximal band. Now, the second idea is how sharp do I make the band? It's easy. The sharper the diagonal is, the sharper is my band. My band sharpness embraces the sharpness of that diagonal. It's a 90-degree diagonal. My band will be close to a 90 degree. Okay. So for example, this is a same LAD size, but sharper diagonal. I made my wire here sharper, same length kind of, but sharper. Conversely here, you have this artery compared to that artery. It's the same diagonal angle, about 60 degree, but it's a smaller LAD. So I made my proximal band shorter. Instead of making it, 6 millimeter, I made it 4 millimeters, for example. Conversely, for that same artery, it's a small LAD and it's a sharper band. So I made it a shorter band and a sharper band. That's how I do it. That's really my technique. And I think, it is important. Wire bending will be very helpful to you in being successful. So really know how to bend your wires. Now, putting a distal band is my personal preference. Not everybody does that. The reason I do it, and it's fine not to do it, but the reason I do it, it's especially when I'm trying to get into a branch, that distal band that I put allows my wire to stay centered. So when I go into that branch, my wire will not hug the wall, meet resistance, and prolapse out of it. It will stay centered in it and more likely to stick in it and not prolapse out. It also allows me, once I get in the vessel, that proximal band may get straightened, so that distal band may allow me to keep some bend and some torque control, some ability to torque. Okay, that's how I do it. Now, in terms of crossing a CTO, I mentioned how you do CTO wire escalation. Well, when you do CTO wire escalation with all those wires, this is how you should shape the wire tip. All those wires here, this is how you typically shape that tip, like this, because you don't want the wire to put you in the subintima. You put a big wire tip, the wire will deflect into the subintima. When you have a CTO, you put a very, very shallow and very distal band, 1 millimeter band at the end and very shallow, in order to stay centered and to try to drill through the occlusion, if that's your goal, to go antegradely. If you're trying to go subintimally, it's a different story. Then you try to make a big band and make it knuckle. If you're trying to go through collaterals, then you also actually do the shallow band, not the knuckle type of band. You make the very shallow tip band, like this one, for collateral crossing. Okay? So this is how I shape the wire. Second idea regarding how to maneuver the wire. One big issue, as you're trying to wire a side branch, one big issue you will encounter is that, okay, you get into it, but as you're trying to go further, you flip out. This is what we call wire prolapse. So there are several ways to avert that. One is the type of wire you use. As I described earlier, it's less likely, much less likely to happen with a polymer wire than with other wires. And it is less likely to happen with a nitinol soft tip wire, such as BMW, nitinol non-core to tip, soft tip wire, such as BMW, than with other wires. Again, the idea with polymer, it's slippery. It's less likely to meet resistance as you're trying to torque it inside, and therefore it's more likely to slip through. So that's one idea, choice of wire. A second idea is what I mentioned here, proper wire shaping, especially I think that putting a distal tip may help you get through that without wire prolapse. The third idea is the technique. So the way I do it, once I get into it, don't push. So you get into it here, you get into this, don't push. You push, you'll get out. What I do once I get into it, I spin it gently, right, left, and with a slight push. So it's mostly a spin and a slight push. This is what we call the turning wheel technique. Right, left with a slight push, and it will find its way and it will slip through and straighten. Okay? And a lot of time, if you cross that, if you're into the side branch, you get into it looking up, you torque it so it looks down without pushing. You just torque it gently so it looks down, then you slightly push it, then you torque it again in the other direction. Okay, that's what we call again the turning wheel. So you have to spin it gently with a slight push to get through it. So that maneuvering, that turning wheel can help as well. The fourth technique that helps you not prolapse is to use this catheter, the dual lumen catheter. This is an example of one of the dual lumen catheters, what we call Sasuke catheters. In this case, you have a wire in the main branch and you're trying to wire a side branch. So you advance the Sasuke, where is it here? You advance your Sasuke over the main branch wire in a monorail fashion. This is your main branch wire. This one is going out as a monorail. Then at the back of the Sasuke catheter, in an over-the-wire fashion, you advance a long wire or a short wire, but it will be eventually you'll have to take it out as an over-the-wire, and you advance it, and it will come out from the side arm, and that side hole has an angle to it, which helps directs you into the side branch. Okay. The beauty of this catheter is that you have a radio opaque marker that you can see fluoroscopically. It's just past the hole, so it can tell you where that hole is for the over-the-wire side branch wire. Okay. This is an example of such a case. This is a patient. He has a tight lesion just before in the distal RCA, just before the PDA PLB bifurcation. We were able to wire the PLB, but it was very hard to wire that PDA past the occlusion. So here is what we did. We used that Sasuke catheter. And here you can see that Sasuke radio opaque marker. So we advanced the wire, and the wire came out of that side port just before the radio opaque marker, and it went into the side branch. Okay. So sometimes keep in mind, this is a Sasuke. It's easier said than done. It's directing you to the side branch, but keep in mind, realistically, that side port may be looking to the other end of the vessel. That side port in a 3D orientation may be looking toward the inner vessel, not toward the PDA. So sometimes you may need to do some torque to that catheter to make you direct it this way, not that way. So that's one thing when you use it. Another thing, though, even if it doesn't direct you into the PDA, I think the most valuable idea with those catheters is that even if they direct you to the other end, is they do prevent wire prolapse. They make it easier to wire side branches simply because they provide a distal body and they make it, they reduce the chance of prolapse once you get into it. And that's the main advantage. Because when you get, even if it's directing you away, the side branch is here, this wire is coming out from here. Eventually you torque it and you get it into the side branch, and it's less likely to prolapse because you have a distal robust body preventing that wire from prolapse. Okay? It's providing distal resistance against prolapse. Now, how do you advance a wire? You know, I described some of the how you shape it, how you prevent prolapse. Now, how do you advance it? And this is, again, very much operator preference. Grossly speaking, there are two types of ways of advancing the wire. One is to direct it and gently push it, which is what we call the directionality technique. And the second technique is to spin the tip constantly as you're advancing. Regardless of what technique you use, do not allow the wire to buckle at any time. And I'll show you examples here. This is a directionality technique. Here we crushed a stent into the diagonal and we wanted to rewire that diagonal. So you want to direct the wire into it. You don't want to spin it at one point. You want to be able to push and grab the diagonal before you eventually spin it. So this is what I call directionality. You provide an orientation to that wire, a direction, an angle to that wire, then you push into it. You have wire control to direct it in that direction. And you see here, we directed in that, we got into it, then we started to spin it to prevent, one, to prevent wire prolapse, two, to be able to advance it safely. And this is a second technique. Actually, sorry, this is another example of the first technique, directionality. This is a lesion that is eccentric and it's medial. So we directed the wire toward the medial aspect to try to cross it. And here, as it's gone medially, it slipped. Okay, so be careful here. A couple of ideas of this crossing. One, you see buckling, and this is what you should avoid when you're wiring. That buckling, very important here. This, you see this? This is what you should absolutely avoid. Whenever you see buckling, as it was done here, you immediately retract. You don't push anymore. Buckling often means you're against something like a plaque, and you're pushing against it, and next you're going to dissect it or perforate. So you immediately retract and redirect. That's one idea of this. Second, once you redirect and crossed, after we directed in that channel and crossed, then we started to spin it to continue to cross the vessel. And here I come to describe the second technique, which is the spin technique. Once you get where you want to go, whether in a branch or across a tight eccentric lesion, using the directionality technique, then to cross the vessel, I like to use a spin technique, the second technique, meaning you keep spinning that wire. Here, this is the wire and this is the torquer. You keep spinning right, left. So you're pushing it while spinning it right, left, right, left. As you're going, advancing gently, you're spinning right, left, as you're going forward. Why do we do this spin? You know, for anybody who's wired, you can tell why, because one, it helps you stay centered and avoid branches that you don't want at this point. You want to stay in the main vessel or the main side branch. You don't want to go into the minute branches. So that's one, it keeps you centered, prevents you from getting hooked into side branch. It also prevents you from getting hooked into any plaque. And it reduces the friction against the wall and against the plaque. You keep spinning as you're going through. You're never frictioning against one plaque or against one side of the wall. Okay, so we advance with a spin. There is another application of the spin technique, little different. So those are the two, though, big technique, directionality and spin, often used in conjunction. The spin technique, and this is an important tip here, is very important for occlusions, whether CTO or actually even acute occlusion or very tight subtotal lesions. This is how we do it. This is, let's say, an occlusion or subtotal occlusion, and this is the wire, and this is the cap. Let's say a blunt cap here. Well, you advance your wire and you want to cross that. So what you do, you position it with its shallow tip and you start spinning it in place. So you spin, you don't push, you just spin it in place, right, left, right, left. You can do one spin to the right, one to left, or some operator do 1, 2 to the left. You know, they do 2 spins to the right, 2 spins to the left, 2 spins to the right, 2 spins to the left, without pushing it. It's just you're spinning it in place with a slight, very slight push. Basically what you're trying to do, it used to be called a drilling technique. You try to make that wire find its way. Eventually, as you're spinning it this way with a very gentle push, the wire will find its place and it will slip through. And you'll feel some loosening of the resistance and you'll feel that wire pop through. Again, without you having pushed much. So you spin in place. You park it at the cap and you start spinning with a gentle push. No buckling. You don't want to see buckling. So this is an example of that. We had a subtotal occlusion in that mid RCA. So here we span the wire in the cap, then eventually it loosens it. So we're spanning it here and eventually it loosens and it passed through. We are using here guide liner and catheter support. Okay. So you twirl it around until the wire finds the way. No heavy pushing, no buckling. It's a standard technique. You can use it also in thrombotic acute MI occlusion. Okay. I want to describe briefly peripheral guide wires. So the peripheral vascular guide wires, I classify them in 4. And those are the wires we use not just for peripheral interventions. Those are the wires we use to advance catheters. And those are the wires we use for aortoiliac and SFA manipulations. They are 0.035 inch, unlike the coronary guide wires, which are 0.014 inch, and the tip of which can get tapered to 0.009 or so inch. So you have 4 categories, in my opinion, of peripheral vascular guide wires. You have the standard J-tip stainless steel wire that we use in advancing it every day, all of our coronary catheters. A variation of that is the smaller J-tip, heavier body Rosen wire. The second category is the soft angle tip stainless steel wire, such as Woolley and Benson wire. The third category is supportive heavy body stainless steel wire, such as the Amplatz super stiff wire. And you have an Amplatz extra stiff. Super stiff is the stiffest one. So you have various degree of Amplatz, but those are heavy body supportive wires. The tip can be a J-tip or an angle tip, but the tip is soft. It's the body that is heavy. The fourth category is that very important category of polymer, very slippery glide wire. The glide wire, you need to know it very well. It's a very important peripheral wire. It can come, so the tip is soft always, but the tip can be angled, straight, or a J, and the body can be stiff or soft. So the body can be heavy, but the angle is always soft. So the common 2 wires I use, actually the most common wire we use in peripheral intervention are what we call angled stiff body glide wire. So angled tip, stiff body glide wire. Sometimes I use angled soft body glide wire, but most often angled stiff body glide wire. It tends to have a very heavy body. Okay. So here just a gross orientation for you. What guide wires would we use to cross peripheral lesion and peripheral disease? So grossly, we don't always use 035. So we use the 035 inch wires for iliac and SFA. For infrapopliteal, we use typically 0.014 inch. But here I put in smaller font. In SFA, you can also use 0.018 inch wires and 0.014 inch wires. In infrapopliteal, you can use also occasionally 0.018 inch wires. And typically for iliac and femoral SFA popliteal, again, the most common use are 0.035 inch. The most common wire is that stiff body angled glide wire, typically with catheter support, quick cross catheter support. Again, you can use 0.18 inch and 0.14 inch, or sometimes you need to exchange to 0.14 inch, particularly when you're trying to do atherectomy, as all peripheral atherectomy devices go over 0.14, not 0.35 or 0.18 inches. So I typically usually exchange for an 0.14 supportive catheter wire, or more typically to an 0.14 spider wire for distal embolization protection. Now, in terms of infrapopliteal, my most popular wire was the 0.014 or 0.018 inch glide wire as well, advantage. In the 0.013 inch, I like glide wire. It's like the 0.35 glide wire, except it's called the glide wire advantage. Actually, the last 25 centimeters of it are glide wire, but the rest of the wire is non-polymer wire. So it can give you more support while continuing to have the good crossability and deliverability. Okay. You could use in the infrapopliteal coronary polymer wire, including the coronary CTO wires, or you can use the heavy tip non-polymer wires such as Confianza and Hornet and Gaia Third. But my preferred wire has been this in general. Okay. Again, you use 0.14 or 18 inch quick cross, which are like the coronary support catheter, like Corsair to a degree. Those are just some pictures here, and I will finish. This is an example of super heavily calcified SFA occlusion that I did. You can see how heavy that calcium is. So typically in those cases, you expect to go subintimally. So you try to knuckle that wire. Here I have a quick cross catheter and an 0.35 inch heavy body glide wire, angle tip. So we try to knuckle, and this is where the heavy body help. You try to push your knuckle with that heavy body of a glide wire, and you try to cross subintimally, which is the path of least resistance in this heavily calcified intima. You go behind it, and you try to re-enter distally at the reconstitution. We cross it with an angled stiff glide wire, and we try to re-enter. You can re-enter either spontaneously with the wire or with an angled catheter. You can use a re-entry device, or you can use reverse cart, get retrograde tibial access and balloon from below and across. So here you can see here, I re-entered using the outback re-entry system. And when we re-enter here, we're using, we got here with a glide wire, but we use 0.14 inch wire to re-enter. That's what this outback system allows us to use, a 0.014 inch wire. This is another case of tibial. We cross the tibia into the SFA, and here we use an 0.14 inch system, 0.14 inch glide wire with an 0.14 inch catheter. And here we cross the popliteal into the SFA. Anyway, that was my talk for today.